Hello, everyone, and welcome to our webinar, Is My Patient Ready for Hospice? My name is Lauren King, and I'm the Provider and Community Relations Liaison at Coastal Hospice. Welcome to our Caregiver Academy. Among our attendees today, we are happy to see so many familiar organizations with us. We have colleagues from Tidal Health, Somerset County Department of Social Services, the state of Maryland, Delaware Hospice, Visiting Angels, and many more. It's wonderful to see all of you today. Before we begin, allow me to go over a few housekeeping items. You may see myself or my colleagues, Alejandra and Joy, pop up in the chat box to address or help with any technical issues. I want to thank you for your patience ahead of time, should we have any. I'll also come back at the end to discuss the program evaluation. We will be using the chat feature to communicate with you throughout the webinar. You can access it by clicking on the messaging icon in your meeting controls. Our webinar today will be moderated by Lauren Blair, Provider and Community Relations Manager. Lauren has more than 15 years of experience in the healthcare field. She is a Maryland licensed master social worker, a licensed clinical social worker in the state of Delaware, and she is on the board of directors at the Gray Center of Maternal and Women's Health. Lauren, I'll hand it off to you.
Thanks so much for that introduction, Lauren. We're happy to have so many clinicians in attendance with us, and I would like to welcome Dr. Joan Carpenter, who is here with us today. Dr. Joan Carpenter is an expert in geriatric palliative care, specializing in caring for older adults and their families. She is an assistant professor at the University of Maryland School of Nursing, a health scientist at the U.S. Department of Veterans Affairs, and a nurse practitioner with Coastal Hospice and Palliative Care. Her practice and research focuses on palliative care interventions to improve the quality of life, reduce symptom burden, and enhance decision-making for persons with serious illness and their care partners. Thank you for being here with us today, Dr. Carpenter.
Thanks, Lauren, and thanks to everybody who is joining us this afternoon, and to the folks at Coastal Hospice who have really worked so hard to put together the Caregiver Academy for the community.
Thank you, Joan. On this next slide, we're going to talk about our objectives. One of the reasons we wanted to address this topic is that we've noticed that so many of our patients end up coming onto our services for only 1, 2, 3 days before they pass away. And that really just doesn't give us enough time with the patients and their loved ones to really utilize all the services that can be provided to them. So we invited Dr. Joan Carpenter here with us today, as she has an amazing amount of experience in not only identifying patients who are ready for hospice, but having these difficult conversations with patients and families. So Dr. Carpenter, what are we going to be hearing about today?
Yeah, Lauren, thanks. That was a great introduction to some of the challenges we see with hospice care, which is a reluctance to discuss hospice and to make referrals, and sometimes just not even really knowing when is the right time. So we're going to talk about some of the work that we do in palliative care and in hospice to help people recognize the importance of their goals of care, and why it's important for providers in the community to help patients establish their goals of care. We also want to make sure everybody comes away with an understanding of hospice services and what hospice can provide for people living with serious illness and their families, as well as we'll talk about some prognostication tools and ways to determine hospice eligibility. And lastly, we'll discuss different strategies for talking with providers and families about hospice care. So for providers to talk to other providers, for providers to talk to the patients and their families, to kind of give you some skills as you go forward in your practice for those attendees on our webinar today.
Wonderful, wonderful. Thank you. So when a person faces a fatal disease that is likely incurable, he faces specific decisions not only about medical treatment, but also about broader existential issues concerning the best way in which to spend his or her remaining time. Tell me, Dr. Carpenter, what feelings does that elicit for you? What thoughts?
Well, it's so true. When a person faces the serious illness news, or the news that they have a serious illness that is likely incurable, that person not only faces decisions about the treatments they may or may not want for that illness and for other chronic conditions they may have, but concerns around, what's next? How is this going to affect my family? How is this going to affect me? How is this going to affect all the things that I had planned to do with the rest of my life that now I'm being told may only be 6 months or a year? And so I think the, overwhelming feeling is one of maybe not knowing what's next, not being able to identify maybe what is going to be the most important next steps in decision making, regarding treatments and regarding the kind of care someone wants. It can be a time of really feeling overwhelmed. So I think, thinking about not just the treatments, but how this is affecting a person throughout all the aspects of their life is important when they're facing serious illness.
That's very good to keep in mind. It can be an very overwhelming time. Exactly. Well, on the next slide, we're going to see some interesting statistics. Dr. Carpenter, will you tell us about the statistics we're seeing here?
Yeah, so we hear over and over again from our patients, and we read in the literature and the research that studies, have shown 80% of Americans prefer to die at home if it's possible. And when you talk to people, most people will say this, that I want to spend my last days at home. Despite these preferences for where people want to receive care at the end of life, most still die in acute care hospitals, also in nursing homes, and really a minority of patients die in their home. Um, a minority of patients also receive hospice care at the end of life. Was just recently looking at statistics, and the median stay in hospice is about 18 days, and this really hasn't changed much in the past 15 years. Um, a lot of times, like I just said, people aren't referred until the last 3 to 4 weeks of life. That is really late in illness, and only 24% of Americans, so really, a quarter of Americans put into writing how they want to be cared for at the end of life. So you can see we have a lot of opportunity in these numbers to make some change, and so really this starts with us as providers, taking care of our patients and having goals of care conversations and talking about serious illness and eliciting preferences that somebody wants, for their care at the end of life.
Absolutely. Absolutely. So we know, because we see every day the difference it can make for patients and their families when a patient passes at home versus a hospital or another facility. But these statistics are still high. Why do you think that so many patients are still dying elsewhere rather than at home?
I think it's, what kind of I had just mentioned right previously, is that we're not always engaging in these conversations in a way that's productive, in a way that we could. I just was with a hospice patient this week who said to me, I can't imagine being anywhere else other than my home right now.
Yeah.
And to hear that this patient was so grateful for the services that hospice was bringing in, because this patient knew that without those services, they would not be able to stay in their home. And to hear that from a patient who otherwise may be in another location was remarkable. And it reminded me why we do the work that we do, and why it's so important, and how grateful patients are to make the reality for them true when they want to be at home. But I think when you ask about the reasons why these numbers persist, it's truly because we have not always equipped healthcare providers with the tools they need to have conversations about serious illness, and about, really difficult conversations. These are challenging, these are hard. We're not all born with a skill set to have, these communication skills, but you can certainly learn them. Everybody can.
I'm so glad we're meeting today to learn some of those skills. It's great. We're going to talk a little bit more about quality of life on the next slide. I think that one issue we don't talk about enough is, what does the patient want to do? What would they like to do with the rest of their time? And how can we help them achieve it? So this is a good death is one that is free from avoidable distress and suffering for patients, families, and caregivers, in general accord with the patient's and family's wishes, and reasonably consistent with clinical, cultural, and ethical standards. Tell me more about this, Dr. Carpenter.
Right. When I think when anyone thinks about death and dying, which is something everyone is going to face, um, everybody wants to be as comfortable as possible. Nobody wants to be in distress. I mean, I never hear somebody saying, well, can't say never. I can't remember ever hearing somebody saying to me that they would want to stress or would want anxiety. I mean, it's a very unsettling feeling, of course. So I think what you see common in both of these phrases here around patient definitions and physician definitions is that a good death is quick, painless, peaceful, without anxiety, and it's comfortable. So there's common themes here, is that comfort is the most important thing. Avoiding suffering is very important, obviously. Avoiding distress as much as possible, and making sure that the care that a person is receiving at the end of life is consistent with what they want, but also consistent with the standards of care for clinical and cultural and ethical standards. It's also, we talk a lot about goal concordant care, making sure that someone is receiving the treatments that they want. And many times with education, with correcting many misunderstandings or myths, we can help people achieve the kind of care they want at the end of life without using life-sustaining treatments necessarily, or without using treatments that might cause more burden than benefit.
Absolutely. There's one misconception that I get from the community a lot when you talk about, the different things that we have and we can take away. When we take away medications, hospice takes away my medications, or I think that's what I've heard in the out and about anyway. So what is that? What is all that about? Why would hospice take away medications?
So, hospice is it's a philosophy of care that looks at the whole patient, right? So sometimes the first time a person is having a healthcare provider look at their whole picture of all the medications at the same time, all the treatments they're receiving at the same time, those, that at that point, when the nurse or the physician or the nurse practitioner or the physician assistant or the social worker or someone is looking at all these medications at the same time, they can say, what, are all of these medications beneficial? Are there any non-essential medications that at this point are not providing benefit to the patient? Perfect example is medications that are designed or meant to delay the progression of dementia. And we know that when dementia gets to be moderate and advanced, these medications are not making much of a difference in that person's quality of life, and sometimes may cause side effects such as anorexia and weight loss, that if we take that medication away, we may see a little perk up in the appetite. So I think, considering that it's not so much taking away medications as taking a look at the person as a whole and their medication list and their treatments as a whole, and having conversations about which treatments and medications and therapies are beneficial and which ones maybe aren't so necessary anymore because they're not providing benefit. With this, we reduce polypharmacy, we reduce interactions of medications, and a lot of times patients do feel better when they're on less medications.
That's very true. We'll see patients perk up. We'll even say, now that I'm on hospice, I feel better. And it's really, like you said, we're having one doctor look at this patient holistically. It's just an amazing, amazing thing.
It's so true, Lauren. How many times have we seen patients really truly perk up? Then the family says to us, they're more awake and they're eating more than they did 3 weeks ago before
Right.
hospice care. What's going on?
Yeah.
It's always a fun question to answer.
It is. Yeah, absolutely. So we're going to talk about various disease trajectories on the next slide. And please, everyone, feel free to put any questions or comments in the chat box. I'll be monitoring them. Dr. Carpenter, will you please explain to us what we're seeing on the screen?
Yeah, this is a great depiction of kind of the different trajectories we see at the end of life. And these have been around since the 1980s, 90s. We'll go through all four, but really the first one on the top left with sudden death, there's nothing we can do in situations where there's sudden death. And these are, traumatic accidents. These are sudden heart attacks. And so what we do know is there's certainly a family that is left after a person dies. And the bereavement stage here is where hospice can make a difference. But we'll talk about that a little bit on the next slide. The next trajectory is around terminal illness, and commonly in the top right, we see this kind of trajectory in people with cancer who've been diagnosed with a cancer that progresses through stages somewhat predictably, that we can kind of track how it's progressing through response to treatments, as well as through over time through imaging, and two, as a person starts to have changes in their functional status, and we can start to see them approach more at the end of life phase a little bit better than we can in the bottom two trajectories, which is around organ failure and frailty. And the first one, the bottom left, organ failure, this is where we see people with chronic lung disease, kidney disease, liver disease, cardiac disease. And we see over time that as that organ as that organ starts to fail. So we may have treatments that can keep a person functioning at a pretty good level and have a pretty good quality of life and be able to do activities on their own. But each time that there's a decline in the functioning of that organ. So for example, in COPD, someone who has an exacerbation and ends up in acute respiratory failure and hospitalized for that acute event, many times we don't see older adults come back to their previous level of function after that hospitalization. It's an extensive time. It might require time in the ICU. It's a lot of time in bed. And so with that, we see people not always get back to the previous level of function. Plus the lungs have, gone through a traumatic event, such as an infection or maybe even intubation and ventilation. So in frailty, the bottom right corner, this is a common trajectory for people with neurodegenerative diseases, such as dementia, many times dementia, Parkinson's disease, MSA, ALS. We just see kind of this frailty over time and a loss of function and a decline in status.
This is such a great illustration of why, advanced directive or advanced planning is so important for us all. We're going to dig even deeper into this on the next slide. There's a lot of information on this slide, Dr. Carpenter. Can you help us understand how hospice and palliative care play a role in disease and different disease trajectories?
Yeah. So this is a great follow-up to the previous slide, because it really, it lays each trajectory on each other, and you can see them kind of all together, and at what point in progressive chronic disease management would you initiate palliative care? Would you initiate hospice care? And importantly, make sure bereavement services are in place for a family after their loved one dies. So in trajectory 1, as we discussed, there's very little that we're able to do to prepare somebody for the end of life, but certainly we can provide support to a family afterwards through bereavement, and hospice does provide support to families for if they lose a loved one, even if they weren't on hospice care. In trajectory 2, where we have the oh, I'm sorry. I said sudden death. Trajectory 1 is I'm so sorry. Trajectory 1 is our terminal illness. This is where we do have, I'm so sorry. I was thinking this was the sudden death one. Trajectory 1 is where we do have the opportunity to intervene with palliative care. So as I mentioned before, that we can provide some sort of maybe, palliative care alongside potentially curative treatments. And then also when those treatments are providing more burden than benefit, we can transition to palliative care and hospice care, primarily hospice care. And trajectory 2, which is our chronic disease or, chronic organ failure, we see that, with each of these, what we call dips or declines, that presents an opportunity to have a goals of care conversation for sure, as you talked about. So every time maybe a person has ended up hospitalized because of an exacerbation of their disease, it's another time to say, hey, how are things going and how have things been going in the past 6 months? So what do you think about coming back and forth to the hospital? In trajectory 3, which is our frailty trajectory, it's a long, slow decline. And anybody who's been a caregiver for a person living with dementia or another neurodegenerative disease knows that this is a time where many people progress slowly through their illness and plateau for long periods of time. So this is trajectory 3 really provides an opportunity at certain intervals, like 6 months or year, even on yearly visits that you may have with patients. How have things gone over the past year? What's changed? How has this person changed in what they can do for themselves, and how much more dependent are they on other people? How many times have they maybe been in the hospital or had declines in function? So, looking back a little longer in trajectory 3 and thinking about, what's changed over the past year, and then maybe what that person can expect in the coming year is important. And that's where having discussions around the role of palliative care and hospice is important. And as you see here, as diseases progress and as illnesses worsen, there's an increasing role for palliative care, and then transition to hospice care when someone's in the last 6 months of life.
And studies show that patients actually live longer on hospice services than those with similar diagnoses and do not choose to receive hospice. So that's, just definitely such a benefit to have. And I love that you brought up that Coastal Hospice provides free bereavement support to anyone in the community, regardless of whether or not they've been affiliated with Coastal Hospice. That's amazing. In the next slide, we're going to talk about where do we start with these conversations. Dr. Carpenter, what is the beginning? Where should we start?
Yeah, the beginning is really just asking a person, what do they know about their illness, and knowing what they know, what do they want? It's so often as healthcare providers and clinicians, we want to help our patients, right? We want to make sure they're getting the best care possible, and that may be according to our definition, not their definition, right? And the best care is really what is best for them based on their goals and their treatment preferences. So, really taking a step back and start by asking open-ended questions, such as, what do you know about your illness? Tell me what you've been told. Who's talked to you about this, and what have they told you? Because that gives you a better understanding right there, how much they know. And maybe then you can ask how much they want to know. And then based on how much they know, what they think about the treatment options they've been offered, and what they want.
Absolutely. Absolutely. So next, we're going to talk about why establish goals of care. Dr. Carpenter, why is this so important?
Yeah, so goals of care really are a roadmap for a person's future care when they're in serious illness. And it makes sure that the patient themselves is in charge of their care and making decisions. And their family who's also assisting with that, not strangers, not people who are, not familiar with the patient. We don't want those, obviously, strangers. We don't want strangers making decisions and sometimes this can happen. This can happen when someone loses decision-making capacity and hasn't appointed someone to make their decisions for them. And they have maybe a distant family member who's the only person that we are able to reach. And that person may be making the decisions. And while that person may be a family member, it's a distant family member. It's someone who hasn't been familiar with the patient and their life maybe. And so, we want to avoid those situations if at all possible, and make sure that when someone loses decision-making capacity, the person making decisions is really familiar with what the patient wants. And that's why it's important to have these goals of care conversations early in serious illness, ongoing, to make sure that we align the treatments to the patient and the family's goals.
Do you find that it oftentimes does take more than one conversation with a patient or their loved one?
It sure does. Developing rapport, developing that trust, really taking things slow. And, oftentimes we're rushed in clinical practice, and we want to have these conversations quickly. And really, it's having more high quality conversations, and they may be shorter in time, but having more times where you can continue a discussion, and that somebody trusts you. And our primary care providers are a perfect example of this. You've been caring for a patient for 20 years. You've developed that relationship. You have that rapport. So being able to have that conversation early in serious illness, your patients trust you. You've built that with them. And exploring what their goals are is so important, and certainly takes a little bit of time, but it's well worth it to make sure that the patient's going to receive the kind of care that they want at the end of life.
So important. Can you give me an example of a time that you felt that establishing goals of care was extremely helpful for a family?
Gosh, there's so many. You know, I think that, a time where the goals were unknown. So maybe a family, I'm thinking about a family who had not really had the conversation and, about goals of care, about treatment preferences, a daughter taking care of her father who was going through cancer, and he was somewhat afraid to talk about things. She wasn't sure, what the next steps were going to be. Our team was called in to help clarify what the goals of care might be. And so by, encouraging each of them to talk together about the illness, about how things had gone over the past year, how things were going to go in the future, what the potential outcomes may be of certain treatments, and what the different treatment options were, including palliative care, including enrolling in hospice care when it was time. We were able to, help this father and daughter, come together, have a discussion, know what was going to happen next. And the daughter was, felt so much more relieved to have that information and kind of the pressure taken off of her, because we all know what we want for our loved ones when we're making those decisions. But we really have to, as a surrogate decision maker, or, is take a step back and make sure that that as a surrogate decision maker, you're making decisions in alignment with what that patient would have wanted when they're no longer able to make their decisions. I think also for a patient themselves, in this particular situation, it was a relief to the patient to know that it was okay to not continue with very aggressive life-sustaining treatments that maybe he didn't want. And it was after he learned about kind of what the potential outcomes of those treatments would be, that it was important that, to him, that he not receive those treatments that he didn't want. And so we we're able to put those things in writing, make sure everybody was on the same page. And, that's one of the very gratifying aspects of this work for sure.
It's a great example. Absolutely. We're going to talk in the next slide about how to begin the conversation with our patients. Dr. Carpenter, we know that it does take time for patients to come to terms with their prognosis. How do we begin?
Yeah. So, just as we talked about developing a relationship of trust, our patients want to trust us now more than ever. I think, in this kind of I don't even know if I can say post-COVID world, but in this, world we're living in where there has been so much distrust of the medical system, of healthcare providers. I mean, we can't ignore what people have gone through over the past 2 to 3 years. And so developing that relationship of trust and making sure that patients know that we are working in their best interests. We want what they want. Our goal is to make sure that they understand that the different treatments that they are asking for, what they may lead to, right? How they may be feeling throughout that time when they're receiving those treatments, and does it really align with what they want for themselves? The other thing is truth telling. And we'll talk about this, I think, on the next slide, is that, people, they do want to know the truth. They do want to be active participants in their decisions. And oftentimes they do want to feel empowered to be able to make their decisions. Or a patient themselves, if they don't want to make their own decisions, they may say, I've had many patients say to me, I'm not sure if I want to make these decisions. I want you to talk to my daughter. I want you to talk to my son. I want you to talk to my spouse. I want you to talk to somebody else. And then they'll come to, and then they'll understand things, and then they can come to me and we'll make the decision together. Right. So that's the other piece of this. And we'll talk about this, is asking a person who they want involved to help them make their decisions. And then the third part is asking questions. Open-ended questions are so important. Listening and providing reflection through simple reflections, just letting someone know that you hear them. Complex reflections, which is, repeating something back to someone to make sure you understood what they said to you, is incredibly important and helps you better understand a person's values and preferences. And it lets them know that you're listening to them as well.
Absolutely. Great tips. Now we come to our slide on truth telling. Dr. Carpenter, what do you feel might be helpful for physicians who are kind of tiptoeing around the truth?
Yeah, I guess, it's natural because like I said before, we as clinicians want to help people. And so sometimes, we're not always comfortable with difficult conversations and with news about a serious illness that's difficult to convey. But we know patients, they want to know the truth about their diagnosis and prognosis. But family members often maybe don't want their loved one to know their diagnosis. And this, in some cultures, this is appropriate. So it's important to be culturally aware, of the patients that we're working with, and what's appropriate within their culture. But healthcare providers also worry that revealing a diagnosis and a prognosis will cause depression, maybe cause a patient to lose hope, right? But these are unfounded worries, and we don't have research that supports these issues. I think what's more important, and what we need to think more about, is how do we give information and give serious illness news in a way that a person is ready to hear it, or ready to engage in a conversation. And many times this is really through asking, as I mentioned before, what a person knows, and asking a person what they may want to know about their illness. I have a really good example of a time where I had a patient that I was seeing in the nursing home for a palliative care consult and had been hospitalized. And I asked this patient, what do you know about what happened during the hospitalization and your illnesses? And this patient told me, I I don't know anything. And I said, well, tell me what you want to know. And she said, please tell me everything. Tell me what's going on because I know things aren't good. I know I'm not well, but I don't know I don't know all the things that have happened to me. I don't know what the next steps are. And um, I said, would you like anyone to be involved in the conversation? Absolutely, my daughter. So we set up a time and we had a conversation. We discussed everything that this patient had gone through in the hospital, what the plans were for care in the nursing facility, and what next steps were. And this patient said, I want to go home. I don't want to go back and forth to the hospital anymore. If I'm this ill and I'm expected to, die in the next 6 months, I want to go home. And so I said, well, I have a really great way to take care of you at home if you'd like to hear more about it. And she said, absolutely. And I said, well, hospice care can help you at home. And here are the things it can provide. And so by, working through that conversation in a way that was empathetic, in a way that was thoughtful, in a way that I recognized emotion, I recognized fear, in a way that I honored her preference to have a daughter present, and I didn't start giving information without that person present, was really important and led to, what I believe is an outcome that the patient wanted and was in alignment with what her goals and her preferences were.
That's so good to keep in mind. What's the patient's preferences? What do they know about, their illness? Such important things that, we maybe take for granted sometimes as clinicians. That's great. I remember another story that you had of a husband and wife who were kind of tiptoeing around each other. Could you share that story with the audience too?
Oh, sure, right. So this was in the hospital, and it was a husband with serious illness. The couple had been married 60 years, and they, had never really been apart. This was prior to COVID, of course. And so the patient, the husband had very serious cancer that was not curable and really was not responding to treatments any longer, and was actually having more complications than benefits and from the treatments. And he had not, when I asked if he had talked to his spouse, his wife about it, he said, no, I've not really wanted to say anything. We haven't talked about anything, and I don't want her to get upset. And when I talked to the wife separately, I said, have you talked to your husband about the illness and about what's going on? And she said, no, I don't want him to get upset if I bring it up. And I said, okay. I said, well, how about if the three of us talk together? How about if I help? Because we really should talk about this. And this is getting to a point where we can't avoid talking about it anymore. This is really, we've hit a point where we have to have a conversation. And the three of us sat down together, and I was able to assist them in having a conversation about the illness and, talking about treatment preferences. And this was another situation where this patient went home with hospice care from the hospital.
That's
So
amazing. Yeah, wonderful. Wonderful. We want to give the attendees some tools for their toolbox of actual language to use with their patients. So I'm going to turn it back to you, Dr. Carpenter, to share with us where to start.
yeah, so we start where, as I mentioned before, where the doctor, what has your doctor, what has your healthcare provider told you about your illness? What have they shared with you? What do you understand? What questions do you have? And really taking time to listen to those responses. As healthcare providers, we talk a lot. We talk more than we need to, and we really need to be listening more. I often ask patients to tell me what's been happening over the past few months. Tell me your story. Tell me how things have been going at home. Tell me how things have been going in the nursing home for your dad. What's changed over the past 6 months. I also ask people what's important to them right now, once and especially it's, using this after you've kind of clarified that they have an understanding or knowledge about their illness. When you think about this illness and you think about what its impacts are on you, what's most important to you, and how do you want to spend your time? And this last phrase is really good for people who are surrogate decision makers. So maybe a person's unable to make their own decision, a patient is, and they have a surrogate decision maker. Saying to them, if your dad, your mom, your brother, your cousin could express their wishes right now, what would they want us to know? What would they want us to know about, what they want for themselves, what's important to them? Always phrasing it kind of in the patient's views as opposed to the surrogates. Not that we ignore a surrogate's emotions or feelings, but making sure that, we're getting at what's important to the patient.
So important. I can imagine that it would be scary to hear that you have a life-limiting illness. Dr. Carpenter, what are the fears that patients have when they're told that they have a terminal illness?
So I think it's the fear of the unknown,
Mhm.
and that's just really from, clinical experience that it's a very scary time. We know that when we give news, what we call sometimes, bad news or serious illness news, when we're um, giving this news to people, oftentimes they don't retain much of anything of we say because they are in a complete state of what we would think about fight or flight. They're just overwhelmed with the news. It's almost sometimes too much, and so they're not retaining much more than they just got really bad news about their illness. And then so that fear of not knowing what's next. And oftentimes as clinicians, we still keep talking after we give bad, quote unquote bad news, instead of taking a moment and responding to the emotion that a patient is going through and their family is going through. And then, taking some time to walk through the next steps of the conversation. People only retain about 2 to 3 things that of the pieces of information that we give them in these conversations. So that's why it's so important to have conversations more frequently instead of longer conversations where you cover lots and lots of topics. Covering, having shorter conversations where you cover 2 or 3 main areas is kind of more important, to make sure that a patient is coming away with an understanding of what the conversation entailed.
That's a very good tip. That's an excellent tip. We're coming up to our next slide. Talk less, listen more. There are so many unknowns and uncertainties. We know that is why it's so important for our clinicians to take their time with patients, like you're saying, Dr. Carpenter. What strategies do you use with your patients?
Right. So, as I mentioned, listening, just taking time to listen and guide the conversation, is important. But asking someone, once you've gotten to the point where they are have an understanding of their illness and they're ready to talk about their treatment preferences, or they've expressed their treatment preferences, asking if they've ever written this down, asking if they've talked to their family about their wishes, or loved one or a friend, whoever they're closest with. And lastly, ask, have they appointed someone to speak for them if comes a time when they're unable to speak for themselves. And I, oftentimes, will say that I often prefer to have a appointed decision maker, a healthcare power of attorney, appointed by a patient, than necessarily all of those different treatment preferences that we foresee in 6 months, a year, 2 years, because having a trusted person who can make a decision about those treatment preferences is important. We know that people's goals of care and treatment preferences change over time throughout serious illness. We know that, and what's more important is that they have, for me, um, that we have those ongoing conversations and that it involves a surrogate decision maker, so they are a part of the decisions as time goes on, and they have a good handle on the values and preferences of the patient, and they have a good understanding of what that person wants. I have so many patients who have advanced directives that were developed 20 years ago, and when we go to call the appointed healthcare decision maker, they're not, we can't find them. Their address is wrong, the phone number's wrong. I mean, people move, right? So I think it's really important to, in the here and now, have that appointed person that somebody wants to make their decisions if they're unable to do so. And then having ongoing conversations about treatment preferences, throughout time. That's the ideal.
Great. I have a question that came in through the chat box from Charlotte. And Charlotte asks, how do we deal with patients and doctors' resistance to the word hospice? That's a great question.
I know, right? And so some of the communication skills I talked about with patients really work with our peers and our colleagues, because if someone says, well, I don't know about hospice, I'm not so sure about that right now. And they're maybe resistant to the suggestion, a great way to find out like what they're thinking is, well, tell me what your impression of hospice is. Tell me what you think Tell me like your experiences with hospice, because then you can understand where that person's resistance may be coming from. So, it's not uncommon for a patient or a family to have had an experience, or even a provider to have had an experience that was not ideal with a hospice agency, with a palliative care provider. I mean, these things happen, right? And so what we want to do is make sure we clarify any misunderstandings or myths, or clarify kind of what it is that hospice provides. Perfect example is, when I ask people, tell me why hospice, why you're not thinking hospice would be an option for you. Well, I don't want to go there. Well, I'm like, well,
Mhm.
okay, tell me what you mean go there. Well, hospice is a place. Well, hospice, we do have a hospice, right? An inpatient hospice unit. We do have a hospice residential house, but hospice is a philosophy of care that goes, is a home care benefit from Medicare that actually goes into the home, wherever that person's home may be, the nursing home, the assisted living facility, independent living, personal home, group home. But it also, in situations where a person needs additional, symptom management that can't be managed in the home, there's the hospice inpatient unit, or a person needs residential care, the hospice house. So finding out what people think hospice is, or maybe what their experiences have been in the past, is really important so we can clarify any misunderstandings.
That's a great tip. Yeah. What do you know about hospice? Tell me what you know. It's great. And we're going to talk about in our next slide, when is hospice appropriate? We know the average time of a caregiver is 4 years. That's a lot of care and support in those years. And there's so many things that hospice can do and provide. So Dr. Carpenter, tell us, when is hospice appropriate?
Yeah, so Medicare guidelines state that hospice care is for patients who have a life expectancy of 6 months or less, should the disease run its usual course. So of course we'll talk about prognostication a little bit later in the presentation, but this can be difficult. But it's important to remember that if you would not be surprised if this person died in the next 6 months, hospice is likely appropriate. Also, when the goals for the patient and family are comfort and not curative, really focused on not using aggressive, potentially curative treatments, and that the burdens of treatment become greater than the benefit. Really good example, and sometimes what we see, and it can be hard to get through, is when people um, are ambivalent. And what I mean by ambivalence is they have two conflicting desires, right? They say, I don't like coming to the hospital, but it always makes me feel better. But I don't like going to appointments, but I don't really want someone in my house. So, like, when you think about this, the person saying, I don't really like to go to the hospital, but the hospital always makes me feel better. And so they don't want the burden of the treatment of going to the hospital, right? They don't want that, but they want the benefit of what the hospital is providing, which is symptom management. So when you think about, someone expressing these, what we call ambivalent um, statements, it's a time to be thinking about what role could hospice play. The other one is, I don't like going to appointments. I don't like going out to do these certain things. It's not really benefiting me, but I don't know if I like someone in my house either. Perfect way to start talking about, tell me what it is about having people in your home. Tell me, what could help, what would be more acceptable to you about having someone come into your home to help you. So, again, these are, where we think about when the burdens of treatment are greater than the benefits.
That's great. That's great information. Great to think about too, is what their, what their misconceptions might be of hospice, and what ways that we can debunk any myths that they may have in their head.
And help them recognize too that they're even telling us that the treatment, the burdens are really great on them,
Mhm.
and that the benefit they may be receiving is a benefit that we like. So for example, like shortness of breath, hospice can help with that in the home. That's a very
Mhm.
scary feeling, and that's why people end up going back and forth to the hospital.
Sure. Yeah. So making sure they understand that we can manage those things. A lot of people don't think realize that.
Hmm.
In our next slide, we're going to talk about the focus of hospice. We have this diagram to explain. Dr. Carpenter, could you help us interpret this?
Yeah, so hospice, really the focus of care is really the last stages of an illness and the dying process, as well as bereavement support for for a patient's family. And the way that hospice can do this is, providing comfort and support, comfort through symptom management, both physical and non-physical symptoms, things like depression, anxiety, existential suffering through pastoral care services. We'll talk about that a little more. So comfort and support for the patient and the family, because hospice is wraparound support. It's, really sees the patient and family as the unit of care. And so there's a lot of support for the family, for family caregivers, education, and making sure they get respite when it's needed, as well as interdisciplinary care. So, we have nurses, social workers, pastoral care specialists, we have physicians, nurse practitioners, as well as, volunteers, nursing assistants, and really, as I mentioned early on in our presentation today, looking at the patient holistically, from all the different disciplines, taking into account the different aspects of that person's life and care.
Great, thank you. Our next slide highlights the services provided by hospice. There's a large number of people supporting not only the patient, but the family and the caregivers as well when a patient is on hospice. So I'm going to turn it back over to you, Dr. Carpenter, to explain the first few for us.
Well, yeah. And so, a lot of people associate hospice care with pain and symptom management because, those of us who specialize in hospice and palliative care really are specialists in managing pain and other symptoms such as shortness of breath, nausea, constipation, so common and so bothersome. Emotional, psychosocial, and spiritual support. It's really important to taking care of the person's, depression, anxiety, and really exploring any existential concerns and suffering they may be having, which our pastoral care folks are so good at doing. And then two, just thinking about the medications, the medical supplies, and the equipment, that's all covered under the hospice benefit. I've had patients, families say to me before, there's no way I can take my mom home. I don't have the equipment to care for her. I don't have a bedside commode. I don't have a shower chair. I don't have a hospital bed. And I said, well, if hospice can provide those things, what do you think? Would you be able to do it? Well, I think I could do it if I had all those different, that different equipment. And so that can be the difference sometimes between someone being able to care for their loved one at home and not. Also around family training and education, making sure they understand, symptom management. During my hospice visits, I have family members who are so proud to tell me how they know how to give the medications, and they show me where they keep their emergency box, and, empowering them to be able to do this work and helping them feel confident in caring for their loved one. And Lauren, I'll let you maybe talk a little bit more about some of these other services.
Yes, absolutely. Yes, such a good point about, training our patients' families. We train them to use the durable medical equipment. So if they have a Hoyer lift, if they have a bedside commode, or even a trapeze, we train them on how to use those things. We train them on how to transfer patients, how to turn them, how to bathe them, whatever the case may be. We're able to have speech evaluations to determine what foods may be the safest for patients to swallow, OT and PT evals to help maximize the time patients have left. We have short-term inpatient care. If there's a crisis, patients can have their symptoms managed at Coastal Hospice at the Lake. Also, we know from, how exhausting it can be to care for a loved one at home. So hospice does provide inpatient respite care. It is absolutely free. That way, the caregiver, if they need a break or they're going out of town or they're having their own healthcare issues, the patient can be in a safe environment, again, free of charge. And something that many don't know when we talked about the bereavement earlier too, is that, we provide free bereavement care to families for at least 13 months after a patient passes away. So the families and the loved ones are being cared for and checked on and supported. We also care for pediatric patients too, and they can continue to receive concurrent care. So they can continue to receive hospice services at the same time that they're receiving treatment for their illness. And I want to point out too that we provide free informational sessions to patients and families. Our access team who does our admissions will send a nurse to your patient's home to provide them with more information on hospice and what services we provide. So please utilize us for these conversations. These are conversations that these nurses are having daily. So, they're quite experienced in it. And there's so many services that we can offer.
I know, Lauren, and I was thinking about Compass. Maybe we should talk about Compass a little bit.
Absolutely. Our Compass program is a free non-medical program. It's a support program. So it's not medical, but it does provide help getting resources in the community. So if you have a patient who is either not ready for hospice or maybe they just don't want hospice yet. Someone with a serious illness, we say that eventually this is going to lead to needing hospice care, would be appropriate for Compass. And we can provide help with things that they may need, such as Meals on Wheels or getting equipment they need. We've even built ramps for people, and we provide companionship. We go right to their homes, and we're able to kind of look around and really get a grasp on what they may need at home. And it's a great way to start introducing the philosophy of hospice care. Our Compass associates are trained on how to have these conversations with patients and families as they get closer to possibly needing hospice care.
And there's always, these situations, unfortunately, or fortunately, I should say, but we sometimes will discharge patients because have extended prognosis, and that's good for the patient if that's what they, if that's in alignment, right? If they're having good quality of life and their symptoms are managed, and we don't always want to discontinue our services though, but sometimes that does happen, and we have those folks can be referred to Compass as well, so that they have that extra support just checking in, because sometimes they will decline in the coming 3 to 6 months after that discharge, and so we can continue to make sure that they're connected to hospice if they decide that, and if the condition warrants that services are needed again.
Absolutely. And I want to also add that we discharged over 100 people last year from our services. So patients who, we did consider, probably wouldn't be surprised if they were, to make it past 6 months. After hospice got involved, they kind of, like we said earlier, they perked up, and we had some things kind of change in their disease trajectory, and they were able to come off hospice. But all those, yes, like Dr. Carpenter said, are followed by Compass, and that way, if they do need to come back on, it's a very seamless process to do so. I want to explain in the next slide who pays for hospice. I think it's important to highlight that hospice is a free benefit. Our patients do not receive bills for hospice care. I want to point out too that physicians in the community can continue to see their patients and continue to get paid under the Medicare modifier. Medicare allows for both physicians in the community and hospice to receive payment for their services. So you have a rapport with your patients in the community, them, and they trust you. And we do encourage the providers out there to keep your patients and keep seeing your patients while under hospice services. And if you aren't familiar with how to bill for this, please contact us at Coastal Hospice, and we would be happy to help. Do you want to talk a little bit, Dr. Carpenter, about the Medicare hospice benefit, and I'll talk about the others?
Sure. So yeah, the Medicare hospice benefit pays for all of the needed things like hospice, obviously the hospice team, the needed supplies, durable medical equipment, and the medications for the symptoms related to the terminal illness that the person is being admitted to hospice for. It does not pay for room and board under the hospice benefit. That is something that's been in place for a very, very long time with the hospice benefit, which quite honestly has not been modified, since the 1980s, really since its inception. But what hospice, provides is quite amazing, truly, to have the supplies such as attends, the different things that wound care, cleanser, all of the different treatments that would be needed for a wound, the durable medical equipment, as we mentioned, the Hoyer lift, and and that really, like I said, can make the difference between someone being able to take care of a loved one at home and in a nursing home. The medications and the teaching really around, managing medications. It can be very difficult for older adults to manage medications. So many times the hospice nurses will, fill the pill containers for the patients. And so that way that takes the stress off the family caregiver to do that, or for the patient themselves if they're still able to live at home alone, which we do have patients who live at home and maybe have someone checking in on them here and there, or maybe have a roommate, or someone who lives close by who's checking in, but for them to be able to stay at home alone and to manage their symptoms. And then I'll let you, Lauren, talk a little bit more about Medicaid insurance and charity care.
Absolutely. So other ways that hospice gets paid for, if patients have medical assistance, Medicaid, private insurances have hospice benefits. And if someone does not have, insurance for whatever reason, we do have charity care. Patients do not get a bill for hospice care. We do not turn away anyone for not being able to pay. We fundraise all throughout the year, all year long, to be able to provide care to our patients. We just had a great fundraiser last week, actually, Blues on the Bay in Ocean City, and we are able to keep patients being able to utilize our services and treatment for free of charge because of those programs and because of that charity care and because of donations from people in the community. So let's talk in this slide about hospice eligibility. The goal of our webinar today is my patient ready for hospice. So Dr. Carpenter, what determines hospice eligibility?
Yeah, and I think, as we've been mentioning, is that the goals of care are focused on comfort and quality of life, which most people's are. Truly, when they're going through a serious illness, they want to be comfortable and they want to have a good quality of life, but also that the patient's terminal illness has a prognosis of 6 months or less, if the disease runs its usual course. And again, that's can be difficult to prognosticate. We're going to talk about it on the next couple slides, though, to give you some tools.
Great. Yes, let's talk about our next slide about core indicators. Will you share with us?
Right. So there are these 9 disease categories that we use whenever we're looking at different diagnoses for hospice. And these are advanced, diseases that are in the advanced stage: heart disease, pulmonary disease, such as COPD, renal disease, chronic kidney disease, end stage renal disease, advanced dementia, ALS, HIV/AIDS, cancer, liver disease, cerebral vascular accidents, and coma. And these indicators of decline, this quick sheet, I think, is really important, Lauren, to talk about, because these indicators of decline are really great ways to say, in conjunction with these disease categories, or if you're seeing these things, it's time to be thinking about hospice.
Absolutely. I want to note that the quick guide to coastal hospice referrals, if you don't already have a copy of this pocket size guide, please let us know and we will get you one. They're so nice to have on hand. Just such a quick little way to look at things. So we have some tools for prognostication in this slide. Tell us about these, Dr. Carpenter.
Yeah, so we just talked about the core indicators. We also have the palliative performance scale, which we use a lot in our daily assessment of palliative care and hospice patients. And really, this is just, looking at kind of the different levels of ambulation activities, the ability to participate in self-care, their intake, and their level of consciousness going from full to drowsy or coma. So we use this a lot in hospice care. The FAST score is used in Alzheimer's dementia, and really those people with Alzheimer's dementia who are really speaking less than 6 words, are not able to hold their head up, or incontinent. That's the stage of advanced dementia where, with the diagnosis of dementia, they can qualify for hospice care. But oftentimes there could be another diagnosis that this person may have that around, maybe they've had a CVA. There may be something else that qualifies them for hospice care. And then also lab values. We look at different lab values around albumin, anemia, different values there.
Great. We want to talk on this next slide about when to suggest a hospice discussion. Dr. Carpenter, do you want to share some of this criteria with us?
Right. Yeah. And a lot of this, we've been talking about throughout the webinar. So really, just to reinforce, when someone's had multiple readmissions to the hospital for the same condition or for different conditions, and you're seeing decline, a terminal illness, or someone who's in the terminal phase of a chronic disease, the terminal, and really, we really want to have these discussions earlier than when they're in a terminal illness. But, when you are seeing that, you wouldn't be surprised if this person died in the next 6 months, when they've not responding to treatments that are focused on cure, that's a time to have the conversation. Maybe when someone's refusing treatments and saying, I really don't want this anymore, that's a time to open the discussion and talk a little more. And as we mentioned, when comfort is the primary goal, and a lot of times comfort is the primary goal, even when they're receiving these, aggressive disease modifying treatments. So just remember that when comfort's the goal, and the disease is progressing, and you're seeing these other indicators.
This has been incredible information. Dr. Carpenter, if there is one thing that we should take away from this webinar today, what would that be?
I think it's that we only have one chance when our patients have serious illness and they're facing the end of life. That's our one chance to make a difference and to have this conversation. Our family caregivers, they may only do this once or twice in their lives. And this is where hospice comes in to provide support. So I think remembering that, we are so privileged to be caring for patients during serious illness and to do the best job possible that we can do to provide the best care possible to them is really important. So having these conversations earlier rather than later, making sure that we're addressing goals of care and thinking about what's important to our patients is so important. And I think, seeing what role hospice can play in there is important as well.
Thank you, Dr. Carpenter. We're here to support you as physicians and social workers and nurses and people in the community. We are here to support you for these difficult conversations. So again, please utilize us. We're here to help. Dr. Carpenter, you have been wonderful. Thank you so much for being here today. And thank you to all of our audience. Lauren, I will turn it over to you to wrap things up for us.
Thank you so much, Dr. Joan Carpenter and Lauren Blair, for this presentation on a topic that may be relevant for many. And thank you to everyone who has joined us today. We hope the information was useful to you. We encourage everyone to attend our next webinar on Tuesday, October 25th at 12 p.m., Grief During the Holidays, Tools to Cope with Loss. Please visit our website to register. To wrap things up, we ask that you take a couple of minutes to fill out this short survey. It's only 5 simple questions. Your feedback will help us bring relevant programs to you, your practice, and those you care for. When you click Leave the Meeting, you will receive a survey from Zoom. We will also send you the link to the survey in the follow-up email to you. This was a presentation from the Coastal Caregiver Academy, supporting and empowering caregivers in our community. At Coastal Hospice, we are here for you, and you can call us at any time on the number on your screen. Thank you once again for joining us. I am Lauren King, and have a wonderful rest of your day.